Welcome everybody, and thank you for joining us on a very rainy day in Sydney. I think every day seems to be a rainy day at the moment, but we had a tease of some sunshine midweek this week, so I'm hopeful that sun's going to come back. My name is Redfern. I'm a senior lecturer in design within architecture, design and planning. I'm delighted to be your chair today in the second of our university-wide co-design seminar series. I'd like to start with an acknowledgement to country. And I'd like to acknowledge the traditional owners of the lands upon which I'm currently based. I'm on Darragh lands in the south of Sydney. And I'd also like to pay my respects to the elders emerging, past, present and emerging, wherever you are based today. We pay our respects to those who have cared and continue to care for country. Now, as I said, this is our second event today in our co-design seminar series, and it's a second overture, and we're going to follow this up with a workshop later on in the year. What we're going to run through today is an introduction to our series. We're going to have some breakout chats to introduce ourselves. We've got a great cohort of people from across the institution. We've got a presentation first from Miriam Rose Ash, then we've got Professor Julie Redfern to speak, and then we've got a Q&A and another discussion at the end. So it's not just listening to presentations, we're hoping that you can get involved in the session too. So next slide, please. So these are the kinds of things that we want to cover in the seminar series. There are so many examples of great co-design practice, great co-design work happening across the university. And we don't really share it very well. We don't really know about it. So the aim of these seminar series is to spotlight that co-design work, to share some of examples, great examples from practice, and also to learn how it happens in other disciplines, how it happens in other faculties, how we're doing co-design. Out of both these overtures, the one we held previously and today, we're hoping to pick out some emerging themes and get some ideas for what we might like to learn in a future workshop, which you'll all get an invite to. Next slide, please. But I'd like to start with a little bit of an introduction about why I'm interested in this space. So I am a designer, but I'm a designer driven by curiosity and storytelling, and that's what actually led me to research, in particular co-design research, which is my field. So lived experience is complex. We know that these stories are often hard to articulate. They're hard to articulate individually ourselves, but then they're also hard to share. And they're hard to share across or to translate across the different platforms or audiences that we might need to share those experiences with. Next slide, please. Now, co-design is a really useful way of visualizing that complexity. It can really help us to give form to the words that we're trying to share. They can help us to give meaning to what we're doing and to also bring together lots of different perspectives. And that's one of the reasons why I really like co-design, particularly in a health context. Next slide, please. I also feel like co-design offers an accessible and equitable and a visual approach to creating meaningful language. So moving beyond just research participants, but actually appreciating people and all the stories that they bring and the way that they bring those stories to our research. It does really support people to give form to thought, both in terms of material practice. So these are some slides of some work with people with chronic pain who are sharing their chronic pain narratives, their health narratives, that's stories that they tell to the health professional each time they visit. Now, those stories are codified, quantified by the health professional, but they lose some of the meaning. So we use co-design to really understand and create a visual language around people's experiences. And next slide, please. Oh. Leah, could I have the next slide, please? It's also an approach that's relational. So it can provide a new sense of knowing about our own experiences and support the building of connection and community. Now, what I think is really critical is the acknowledgement of experience in that, creating spaces for people to be heard. Now, I really, at the moment, I'm feeling quite strongly that that's not about giving voice. I'm hearing lots of people writing about giving voice, but actually it's not about giving voice to participants, because as researchers, we are not in the position to give voice. It's about enabling a space for voices to be heard. Next slide, please. And I've been applying design in a community setting for almost 20 years, and I've seen some great examples of co-design practice, but I've also seen some really bad examples of co-design practice, and I've seen some bad and often unethical examples. And for me, it's not just a toolkit that can be applied, but it's actually a practice. And I think that's what's great, to be able to use this platform today to share our different practices, to understand how we're using co-design across the university in different ways and how it's been applied and what the value is for us in that settings. We've got 2 presentations to share with you today to give you a taste of some of the work that's happening. But first, we're going to start with some small breakout introductions to allow you to introduce yourself, what you do and why you came along today. I'd also really like it if you could change your Zoom name, your Zoom avatar, to your own name and tell us where you're from. So which faculty of school? And hopefully you'll get to meet somebody new in these introductions. Janani is going to put you into those breakouts now. We're going to have about 5 minutes for this activity, and then we'll come back into the presentations. Welcome back, everybody. I hope you had the opportunity to meet somebody new and share a bit about yourself and about why you're here. What we're going to do now is go into our first presentation, and I'd like to introduce Miriam Rose Ash. Miriam is based within the research portfolio here at the university, and she's the manager of researcher development. Her work really focuses on researcher career and skills development, so great for us to have her with us. And she co-wrote the university's research impact modules. She also manages the internal researcher development programs such as SOAR, and she really cares about supporting capacity building in researchers at all stages, and she's passionate about co-design. So I'd like to hand over now to Miriam. Thank you.
Thank you. And Leanne, can you give me the thumbs up if you've got my slide looking good? All right, fantastic. So it's great to be here with you all. I'm zooming in from Wongal and Gadigal land this morning. And it's really fantastic for me to be able to organise this seminar series together with the Policy Lab and our academic co-chairs like Leanne. So I'm not going to talk for long. I'm going to talk for about 5 minutes, and I'm just going to touch on why we in the research office are interested in and care about co-design. But first off, I'm just going to touch on my own story, I guess, and how this concept of co-design came into my world. And previously, when I was an academic, I was a biochemist, so I was a structural biologist, and the focus of my research was bacteria and yeast. So there was not a single human anywhere to be seen in the research that I conducted. So I left academia about 7 years ago, and I moved into the research office and research support. And then almost by chance in 2019, I was invited to attend this workshop on consumer involvement in health research, or community involvement. And so I went along, and it was co-presented with a community member who was involved in research. And for me, that workshop stands out as being quite transformational in introducing me to a new world and a new way of thinking about research and conceiving of how research is conducted and planned, involving and deeply involving community. So having had that experience, when Amanda from the Policy Lab approached me and said, you know, what do you think about this idea of a seminar series in co-design? I was absolutely thrilled to be involved. But if we return to this question of why co-design for the research office in particular, I mean, I think it's probably self-evident that first and foremost, we're looking to do everything we can to support research that's going to have some public good, with co-design being a clear mechanism to achieve that good in the world. And then the other reason is we're also interested in, as much as we possibly can, creating an environment that supports you guys to be able to do this work and do the research that you're passionate about. So I'm really, really keen to interact with you all throughout this workshop, but also our workshop that's coming up in May, at which we'll talk about environments at the organisation that support co-design and different examples of good practice that are going on, and to learn from you guys throughout that. In terms of the work we do in the research office, there's a few key areas that clearly are relevant to co-design, one being ethics and IP that I understand has some more complex issues in the co-design area relative to non-co-design research. We're also really interested in research impact and finding ways to enable and increase research impact, as I've pointed to, research for the public good. And finally, another example is grants. And I know this from my former job. So I worked for 5 years in grant strategy and grant development. And throughout that time, was very noticeable to me that, especially in the health space, there was an increased interest from funders in terms of supporting and incorporating co-design into research proposals. So one key example is the NHMRC Clinical Trials and Cohort Studies Scheme. So for those not from the health space, NHMRC is the core government health funder of health research. And in this scheme, co-design is even incorporated into the assessment criteria. So for significance, was this research developed with broad and meaningful involvement of research end users to ensure it meets their needs? In terms of the research itself, does it include highly appropriate researcher and research end user involvement? So when I was reviewing grants and dot points like this were introduced, it became evident to me as I reviewed grants, there was a real difference between those grants that demonstrated deeply meaningful end user or community involvement and those where it was perhaps more tokenistic. So I'm really, really interested to learn more and to go through these seminars with you. So I'll pass back to Leanne, who's going to introduce our keynote speaker. Thanks, Leanne.
Thanks, Miriam. That was great. Okay, so I'd like to move on to our next presenter now and introduce Julie. I'm delighted to welcome Professor Julie Redfern. Julie's a professor of public health. She's also the 2022 New South Wales Women of Excellence and an NHMRC Fellow. She's a practicing physiotherapist, a research academic director in the Faculty of Medicine and Health, and also a professorial fellow, that was a mouthful, at the George Institute for Global Health. Now, Julie has more than 20 years experience of co-design and implementation in health and medical research. So we're really lucky to have her here sharing our stories today. Welcome, Julie, and I'll pass straight over.
Thanks, Leanne, and thanks for having me, everybody. I'll get straight into it. See how we go. Okay, are we good? You see my slides? Yep. Okay, so as everybody has said, we're talking about co-design, and I was asked to just present a perspective, in terms of health and medical research, which is my area of work, as you just heard. So hopefully we can have some questions at the end. So I am a physiotherapist, and I think for a long time been sort of interested in interaction and how do we get people, how do we sort of support patients and people to do the things we would like to do to improve their health. And maybe some of you have felt this, maybe somebody has felt this, and I think historically this has been a little bit of the medical model. One goes to a doctor, as in this picture, a male doctor, but in any case, where they're given all of this information and told, you've got to do this, you've got to do that, or you're going to die, or you're going to have to take this tablet every day for the rest of your life. And this has been a sort of a traditional way things have been done in doing things. So I guess that's just a cartoon kind of illustrating that, but this kind of gets me thinking, as a physiotherapist a long time ago after I graduated, is that really the best way to support our patients to actually do the things that are evidence-based to help improve their health? So this slide just represents, obviously, that interaction can lead to this kind of messy, understanding where maybe there's mixed messages, and maybe the person, the patient, in my case, or in our case in medicine and health, doesn't actually understand what has been articulated and therefore can't actually implement the things that would be potentially of benefit to them. So this is kind of where I came from. And I obviously am not going to talk about cardiovascular disease, but I do just want to kind of just say this one slide so you know about my research and where it's come from. So I work or have worked predominantly in the area of cardiovascular health, so heart disease, mainly prevention. And we know that this is the leading cause of death and disease around the world. And as people are getting older, more people are living with cardiovascular disease. So we've got good treatments, but we've got more people alive and living with cardiovascular disease. So more people needing help and support after heart attacks, for example. But we also know it's a chronic disease, so it doesn't resolve actually, much to contrary ideas and maybe historical thoughts. You don't actually just get better. It's something people have to do, you know, make multi-dimensional changes to their life for the long term and for the rest of their lives. So I'm just laying the seeds here so you can understand where I'm coming from when I talk about the co-design examples in a minute. So, but, you know, from a very early stage in my career, when I started doing my PhD, started to understand that managing the risk factors and the prevention of cardiovascular disease requires consideration actually of psychology and behavior change. And when I did psychology, apologies to people out there from psychology, but I didn't enjoy the psychology of my undergraduate physiotherapy degree. I couldn't really see how it fitted with me being a physiotherapist, unfortunately, at the time. But I've since come to realize it was fundamental to everything that I need to do, including my research now moving forward. So I think that was interesting. And we had to do it in first and second year. But now it's become so important, but it's part of this whole co-design thing, I think. So in any case, we need some kind of improved strategy around reducing cardiovascular risk. So this kind of led me to this concept, you know, back early on in my clinical career and then even before my research career, very focused on putting the patient first. So how do we communicate in a way that's adaptable and responsive to our patients? How do we design, you know, the functionality of interventions to help try to overcome those things? And then that led me to do the primary study in my PhD, which I started in 2003. And it was actually called the Choice Study. And it was about giving patients choice. And I didn't really know much about co-design, or I hadn't heard of co-design at that time, but I do think it's relevant because I designed that intervention myself, basically with colleagues, but also with patients. And then that intervention was about giving the patients choices, options on how they would manage their heart disease risk. So whilst it wasn't co-design, actually, it was about me starting to already be in that space of patients having a say in how we help them manage their condition and how everybody is different. That then led to another few things around health services things and trying to think about flexibility and adaptability in the way we deliver health in a health services model. And that has continued to be the focus of my research. And we did develop a thing we called the SPAN, Secondary Prevention for All in Need framework. But that's about, you know, being adaptable. It's not one size fits all in terms of a health system. It's about different strategies for different people and different systems. So I'm just, again, laying the groundwork for where we've sort of gone from there. Again, this is a bit of a layout about the CONNECT study, which is a randomized controlled trial, which was funded by the NHMRC. We started to conceive this then in about 2012, 2013. And of course, you don't need to know the detail of this slide, but basically to say we got money from NHMRC to do a randomized controlled trial in general practice. But it was about a consumer directed, so a patient sort of hybrid app. So an app that sits on a person's phone but connects to a website, and that app is electronically integrated with the primary care doctor's electronic record. So when you go to the GP and everything is typed into a computer, this app, a web app, was going to directly pull information in and out of the GP, you know, software computer system. So that was the intervention. Now, obviously, then there's outcomes, and the study's completed and published in the Nature journal Digital Medicine. We went on and recruited 930 patients and found modest improvements. But again, that's not the focus of why I'm saying this. What I'm going to tell you about now is how we develop the intervention using co-design. So we've published a number of papers around this work. So I'm going to show you a few, and if you're interested, you can go and have a look at these publications. But this is, I think, the most relevant to the co-design in this particular study. So as I said, this was really starting to come out in 2013. And this is when I really got exposed to co-design and what it was all about. And it was in this context of digital health development. And many of you will have known more about co-design, before that. But this was when it really started to come to the forefront for me. So I was based at the George Institute at the time, and this is the publication that really details the actual co-design process. And I'm not going to go into it in great detail, but I'll touch on a few things in a minute. But a few principles here, and I thought that the diagram on the right really kind of summarizes things nicely. And we often don't do this as well as we could. But basically, co-design in health and medical research is very broad. But it is, as previous speakers have said, iterative and continuous from the inception all the way through to the dissemination and beyond that, which I'll come to again in a minute. It's co-designing a study design, co-designing amongst the clinicians and with patients, with other stakeholders. It's co-designing the intervention, which I'll tell you about in a minute, and testing all of that. It's about co-designing how we're going to implement the research, where, who, how, and working as a group, not one or two individuals thinking they know the best way to do this. We need to involve patients, clinicians, stakeholders in everything we do in health and medical research, as in other groups as well, but that's critical here. And obviously it's continuous. If you want to implement and have impact, it needs to be ongoing after the trial itself might be finished. So creative and participatory methods are used, but we also, I think it's important for me to say, we also need to be pragmatic. I could spend a whole $1 million NHMRC grant going round and round in circles with co-design to try and get it perfect. That won't happen either. So you have to kind of have boundaries, be pragmatic, but keep moving forward as well. And research is evolving. So I think that is an important point to make, and maybe someone might want to come back to that. In terms of the Connect intervention, we did use the FOG behavior, model. And if you want to look this one up, there's quite a bit of research on this. I'm not really going to go into the detail, but it gives you something to look into, where FOG has published in Persuasive Technology Journal, back in 2010. And pretty much this is about, understanding how we get people to be having high ability, but also high motivation to change their behavior. And the importance of co-design in achieving the optimum here, the target behavior here, where we have this kind of high ability, but also high motivation. And how do we design our interventions to hit that sweet spot? So I'll leave you to go and look that up. And this is a summary. It's a bit of a busy slide, but it's a summary of what's in that other paper. I wanted to say that at this time, we actually went to an external consultancy company called Sticky Design Studio. This is where I really learned about co-design. So we actually paid Sticky Design to run the co-design component of this particular study, but I did learn a lot through their work. And I'm just talk through the phases. So we had to do a phase one where we worked out who were our target audience and what were their needs. We had to look at literature. We had to look at what other apps were around. We had to build contextual insights by talking to patients, which I'll show you in a minute. We then did pilot testing and refinement to actually co-design the look and the feel of what that app and interactive portal would look like and how it would be used. And so we had, we even had sort of paper versions of this and that, and we sat around a room with all sorts of documents and pieces of paper that people could jiggle around and stick things on different giant mobile phone screens where things would work, how things would work well. So that was co-designing in terms of that very practical sense. We then obviously had to co-design the software. We then had to validate it. We had to involve clinicians who had to review content and various other things. But there's also beta testing and user acceptance testing, or UAT, which has been ongoing, and then obviously extending out into the intervention implementation and also the post-evaluation of the trial. And I can't go into the detail here, but just to show you all of the different layers, I think. And obviously you're not going to be able to read this, and you don't need to, but this is called an example of sort of a patient persona. And in these, you sort of work out some different types of patients that you're targeting. So what are the needs of these types of people? what are their motivations, what things frustrate them about the system or their health, what relationships do they have with their doctors and other providers, are they capable with using technology, and also how can this Connect help them. So we would develop, I think, about 8 of these different personas that then help to inform the next stage of development in the phase 1 that I just articulated. So we also went on to develop these user journey maps, which you've probably seen this sort of thing before. Again, then you get all the consumers and the people involved in the co-design and the stakeholders. You know, what are all the various things along someone's journey of experiencing a heart attack and how they get managed? And what are all the sort of roadblocks and things they need to navigate, and start to unpack those different layers of the journey. And then eventually you will co-design the solution to kind of pick up on a lot of these things. So we came up with this journey map, and you can see these things in the publication. So we eventually then developed the web app, as you can see here, the Connect intervention. It was very, it was very complicated, but very rewarding to develop this. And you'd be surprised how challenging it is. The colors, the layout, the content, the structure, the flow, all co-designed with all sorts of different people. So I think it's a good example. This is kind of what the user interface ended up looking like. And we have sections where people can learn things, they can act on things, they can share things, and then, standard kind of settings that you might expect. So that's the Connect. And I'm not going to go into too much detail about any others, but I also wanted to just show you some work by Anna Singleton in my team, who's gone on to do some text messaging co-design for people who've had breast cancer. Her study has been called Empower SMS, and you might have heard of this. And the reason I really just wanted to show you this slide from her work, again, this co-design work is published in the Journal of Medical Internet Research. But basically, she's done, workshops with consumers and stakeholders. She gets people to review messages and rate those messages. And I think, interestingly, in that co-design, she really evaluated the difference between what the patients thought was helpful and useful and understandable compared to what the clinicians thought was helpful, useful, and understandable. And that was very different in about 26% of cases, I think she said. And she always favoured the patient then when working forward. But the co-design involves those surveys, workshops, but also focus groups and workshops ongoing after the intervention. Another of my team who's been doing a lot of consumer engagement and co-design, and I think you can't speak about this with consumer engagement, i.e. user, that is your co-design sort of concept. And this is Dr. Stephanie Partridge, who's been doing some work with young people. So really working in a co-design framework with youth and young people. And I think that work is a really good example. You really, how can we as adults, assume we know how bad and others. I've got 8 years, but it's actually 10 years now. So we come up with this concept of text messaging to support people with help in their health. And you can see a whole series of steps here that we've been through that's ongoing now. But basically from an original idea in 2010 and how we've kind of shaped all of this text messaging work. In 2014 is the publication down the bottom, where I published the whole process about how we did the co-design of the content based on theory and behaviour change, involving all of the stakeholders, consumers and end users. And that's now been used by many, many, many groups in developing this type of thing. So we've then gone on to use that to remodel that in various other groups, right down to the bottom here, where we've now expanded to over 20 disease groupings, including youth wellbeing, breast cancer, kidney disease, diabetes, back pain, mental health, many others. So it's another example of a sort of co-design process. And I think I just wanted to put this slide from when we first started doing the work, when there wasn't even really people having smartphones and iPhones, as it were. So, I think we have to be adaptable, and co-design helps you to be adaptable, that it's designed and then you have to read. So it's constantly changing as technology in this case changed. And then this is just a slide which you don't need to understand, but showing the complexity of all of these things. And co-design, I think, is about all of these different people. And how do you actually do something that kind of might work for more people? And so that was really the point of that slide. It is complicated, but I also wanted to come back to the point that we have to be pragmatic and we have to still make things happen. We can't spend all of our time spinning our wheels in phase one of the development. We have to get on and get it tested with people. So I think this is my final slide, and I think this one's probably critical here for the co-design and represents the whole thing to me in some ways. And that is just about everybody is different. And how do we get everybody to try to do the best we can to help them with their health? And trying to do one way is not going to work. And that perhaps was a more
wonderful examples from practice there, and actually things like your principles and some of the successes and some of the times where it went wrong. That's really important to hear those stories as well. So thank you so much for sharing. Now we have 20 minutes left and we've got a small breakout discussion, but does anybody have any initial questions for Julie? Anything that's jumping out that you want to ask?
Can I ask a question?
Yeah, go for it, Elaine.
Hi, Julie. Thank you very much for that. Very interesting. Even though I'm in a totally different field, I work in a business school. So many parallels and things that we can take away from that. So thank you. I just wonder what are some of the issues that you've seen with co-design from people not in the sphere or not involved in what you're doing, but people who sit outside and don't quite understand it? What kind of, how do the reactions, does everyone think it's great, or do you get, pushback?
Yeah, look, I think it's a really good question. I think, I'm not a medical doctor, but I've worked with medical people for a long time. And I think traditionally, the medical training, for example, was we are the experts and we tell patients what they need to do in order to improve their health. And that has been a little bit of the traditional model. Obviously, things are changing and we're trying to get things to change. But I think, flipping that on its head and saying, oh, actually, we're going to do things not the way we think, we're going to do things the way maybe, in my case, the patients might think might be better, is a challenge. And so I think that's one challenge, and that, moving from that I'm the expert to, shared development and contribution and ownership or whatever you want to call it. I think that's one of the challenges. I think the other challenge is time, and that's why I touched on that. You can get very caught up spinning wheels and going round and round in circles because there is no one solution to any of this. So I think being pragmatic is critical in order to keep moving forward. You've got to give your best shot and your best chance to help the most that you can, but it won't always be perfect, and it can't be perfect. Human beings are completely different, so we can't get a perfect solution. So I think, I must admit, when I review grants and I just see this development, I'm like, I don't want to see development. I need to see what you're actually going to do with it. Then again, I'll see other grants going to do it and they don't have the development. So I'm critical of both of those. But I think probably time and challenging those more, I guess, deep-seated in some of those traditional beliefs, and that wouldn't only apply in medicine, it would apply in other areas that the expert needs to be able to sort of let go, I think would be the two things that come to mind off the top of my head.
Fantastic, thank you.
We also have a question in the chat, Julie, from
And you know, it was really great, I've got to say, because it helped keep us all on track. As an academic, we're very busy doing many things, and we had enough funds that we could pay because we had an NH&MRC grant. In saying so yes and no. In saying that, I wouldn't go back and pay again, because I kind of felt like, oh, it was quite expensive for what we got, but they did kind of keep us on track. So it's a bit of a yes and no. I don't think you can really go wrong. You have to spend a bit of time getting an external group up to speed with what you really want to do. So that's the balance always, because they won't have a clue and understand what is, you know, a risk factor for cardiovascular disease or heart disease. So you have to spend your time doing that at the start, rather than just getting stuck straight into it, because at least you know all of the sort of ballpark ideas. And ultimately you still have to find all of the patients, all of the stakeholders, you know, come up with all of the content and the, you know, everything else. So maybe it's about a little bit of training. Maybe it's also about not overthinking it. But you could, yes. And, you know, I mean, it's easy for me to say because I did do that and I did learn a lot from that. Not a very clean answer. No, yes,
that's perfect. Perfect answer. Thank you. Anybody have anything else?
Can I just follow up? I'm just curious, Julie, in the health space, how common is it to use external facilitators for that kind of work?
I'm not too sure. I mean, I don't think it's that common, but I think it's a good thing in reality. I mean, I think we ended up with this whole, you know, I mean, this was at a time when no one else was really doing this much. People were doing it in engineering and other groups, but not so much in health research. And I think health research is a little bit, you know, coming from behind the 8 ball in some ways in this space. I think everyone's been assuming they're the expert. So I don't think it's that common, but that doesn't mean that it couldn't be. But then again, you know, places like this, you know, we have a lot of expertise with how to do this. But, you know, then I think I can't get 20 people coming to me asking me how to do it because I don't have any capacity. So it's a balance between capacity, funding, efficiency. You still have to do a lot of work regardless. So
great, thank you. Okay, I think we'll now go to a small breakout room. When we go to the breakout rooms, we've got a Padlet that we've set up to just capture some of your thoughts. So have a chat with the people that you go into your breakout room with, and I'll show you the Padlet here. So we're looking for your thoughts on what did you find interesting? What were the sparks that you got from the presentations? What are the questions that you've still got remaining? And what would you like to learn more about? Now we'll come back at the end to have a chat around some of these, but try to have a discussion around that. Try to fill in as many as you can. This will really help us as we move forward into the workshop, and we can see how we can start to address some of those areas that are maybe our needs that you might have. So we're going to put the Padlet into the chat. Yep, it's there already. And Janani is going to put us into some breakout rooms. So we're going to take about 10 minutes and then we're going to come back and we'll catch up at the end. We have heard some, I think in our group particularly, there was an overwhelming note of positivity around co-design and the potential of co-design, and just a general desire to learn more about the practice and to know more about the principles. And I think that came up across those Padlets. What we're going to move into next is a workshop on the 12th of May, a face-to-face workshop now that we're starting to get to that place in the world. So it'll be great to see you all in person. And please do enroll and register for that. Amanda's just popped the link into the chat there. So it's going to be on the 12th of May at 9:30 till 12:30 at the Policy Lab. And we would love to see you all there, and we'll just discuss this further and see where we can go beyond that. But thank you all so much for your contribution today. And thank you again to our 2 presenters and to the whole team. Well done.